Well, we will go ahead and get started. I am honored and excited to introduce Dr. France from the University of West Virginia. I think most people, if not all people on this conference, know him or have learned something from him over the years. I've certainly learned a lot from him over the years, and that's why I'm very, very happy he's agreed to do this, even though I think we're interrupting his skiing right now. So, he's going to talk to us about cervical facet dislocations and cervical trauma. And this is, I've heard parts of this from him. We've talked about this before. He's presented parts of this, and it's fantastic because he brings a wealth of experience, a wealth of study, a wealth of teaching. He's done all of this in this area, and it's something that many of us do slightly differently. Some of that depends on center to center, what resources are available that kind of guide when you do what and the order of operations. And I've always found his discussion of this to be so much clearer than when we argue amongst ourselves about what to do and when and why. And so I'm excited to hear more. Please put your questions in the chats, and I'll try to keep an eye on that while we're going today as well. And with that, Dr. France, I'll let you kind of take it away from here.
Great, thanks, Mike. And that's a perfect introduction because I think there are a lot of ways to handle these problems, and we can have our preferences, but there are certain principles and things we need to follow and obey to make that work and to do it safely. And so it's some of it's personal, some of it's institutional. We'll start with a little case example, and then I'll work through this case a little bit as we go through the talk, and I'll show you other examples as well when it's appropriate. And this is a 27-year-old male, high on methamphetamine, high speed motor vehicle crash over an embankment, partially ejected, multiple trauma, neck pain, and you can see his neuro exam quite severe. And he's testing as an Asia A. So he looks like a complete spinal cord injury at this point in time. And you can see his pretty severe facet dislocation. Here's just some axial injuries. He has a partial lamina fracture at C1 ring, but the ring itself is actually intact. So what are our next steps? How do we do this? Do we do an awake traction reduction? If we're going to do that, do we need pre-traction MRI? Should we get a post-reduction MRI and then go to the OR? Do we go directly to the OR? Do we do traction reduction in the OR? Do we do an ACDF? What if the reduction fails? What if the ACDF alone is not stable? When's an open posterior reduction feasible? And so these are all really relevant questions that we'll try to address in the course of this. But when we do this, we have to really, we really want to keep this simple, we have 3 treatment goals. This is true of all spine trauma. We want to have a neural decompression. And in the event the patient has deficit like ours does, this is really the priority. In addition, we need to assess, is a realignment necessary? And then lastly, how much do we need to impart stabilization? And one of the things we know, sort of intuitively, like we all feel like if there's pressure on a nerve, we should relieve it as soon as possible. That makes sense to us. But if you look at even the data, and this is probably the best done study on timing of decompression, and unfortunately ended up using 24 hours because I really do think the sooner the better. And even at 24 hours though, the 2-grade improvement in Asia scores was significant in the early reduction group. So it does seem we can get a more robust neurological recovery by early reduction. And really, it may be that 24 hours is even a limit. The sooner the better. So what we know about facet dislocations is if we realign the bone, if we do a reduction of the fracture, we will have effectively reestablished the canal anatomy. That's assuming we don't have an anterior disc herniation. So this is sort of unique to cervical facet fractures. We don't really have this dilemma in thoracolumbar trauma. So how do we time that reduction? Is this a closed traction reduction in the ER with the patient awake? Is it an open reduction under anesthesia? Is it a closed reduction but in the OR immediately prior to surgery? And how do we use MRI and time out MRI? So we know that MRI is a better assessment of the soft tissue. That includes the disc herniation. unfortunately, it requires quite a bit of time and personnel. It's hard to get somebody in and out of an MRI scanner in in less than 45 minutes to an hour. They're often in inconvenient places in the hospital. The access can be variable and quite often requires a lot of patient transfer. So we do want to minimize this. The really some of the concerns came about traction reduction with some of these papers, mainly the Eismont paper in 1991. And based on this, people recommend that there would be a pre-reduction MRI to look for disc herniation. And it's very interesting because if you look at this paper, if you look at this paper carefully, there were 6 patients. Only 2 of the patients worsened neurologically. And one of the patients had an unsuccessful closed reduction without any deficit in the course of the reduction, was taken to the OR, had an open posterior reduction without pre-op MRI, and that patient worsened. That's really the only patient that worsened with surgical intervention. One patient had an unsuccessful closed reduction without neurodeficit. Again, on a myelogram, showed disc herniation, so it had an ACDF and a posterior fusion. This patient worsened 48 hours later from ascending necrosis. They also had 4 patients that didn't worsen neurologically. 3 were successfully reduced closed with traction, no deficit, but on an MRI post-reduction were noted to have disc herniation. And then 1 patient had an aborted closed reduction due to some upper extremity paresthesia. There's a huge number of papers that have looked at that reduction without MRI, have been proponents of this. These were really around the time of that paper and before that paper. And if you look at this paper, for example, there was a 98% successful reduction, but MRI after reduction showed 22% of those patients had what was called a disc herniation, but none of those patients worsened neurologically, even though it was present. If you look at some of these other papers that advocated for closed reduction with traction, you can see the incidence of disc herniation in these papers is quite high, but the percent of neurological deterioration under traction reduction in those papers was 0%. People have even looked at pre and post reduction MRIs, and there's actually a higher number of disc herniations post reduction on radiographic interpretation, but none of those patients in this relatively small population deteriorated neurologically. And I think the reason for that is traction reduction is very different than open posterior reduction. Traction reduction requires distraction, gradual distraction, and the vertebral body essentially goes up and over the disc as it reduces, as opposed to a posterior reduction where there's a flexion moment and the cephalad vertebral body is drugged past the caudal vertebral body, thus dragging disc into the canal. It's a very different mechanism, so the risk is much higher. This is just an example of a closed reduction. You can see the gradual distraction that occurs before any translation and then reduction. This is just another example showing MRI with disc herniation prior to reduction, and post reduction, you can see that herniation doesn't exist. So you can see that post reduction, that disc herniation isn't present.
John?
I think with the role of MRI, we have to be very aware of a posterior open reduction under anesthesia or a reduction in an obtunded patient that can't cooperate.
John, I
Because
don't know if you can I don't know if Alex, did you have a question or I
Yeah.
thought I heard?
Yeah, John, thank you very much.
yeah,
So impressive images, a huge amount. Are you sure that we are seeing a disc herniation on this MRI?
that
Can
is,
you always be sure it's not a hematoma or something
I
completely irrelevant?
yes, that's an outstanding question because when we get these particularly pre-reduction MRIs, if you look at this one, for example, is that disc material or is that just edema up behind the canal? And it's very, very hard to know for sure. This one I think is probably disc based on the density of the material, the color of the material. But I will tell you, I think it's very hard to tell. And I think sometimes what we're seeing is really edema, and it tricks us. And so I think if I'm going to do an open posterior reduction, which is the highest risk, I'm gonna have a low grade, a low level of I'm more likely to call it disc herniation. Whereas if I'm doing a traction reduction, I'm going to be less concerned. But that's an excellent question, and I don't think we have an answer to it.
Yeah,
So,
thank you.
I think, and what my experience has been, I've only abandoned one traction reduction. We went immediately to MRI, and there was no disc herniation. And I think usually when we're getting neurological deficit during a traction reduction, it's due to over distraction. And I think when we back off the traction, it'll ease up. So I think you do need the patient awake for that. But I think when they develop deficit, it is more often than not from distraction rather than herniation. So some of our MRI issues are also facility dependent. Some hospitals, the MRI is very far away. It's difficult to get to. Um, and it's less reliable. So
Do you mind? I don't mind. I don't want to belabor this, but instead of asking at the end, do you mind just one more time talking about the difference in the biomechanics? I'm not sure I totally get it of
yeah,
the closed versus open, and I'm not sure if the difference is because in the operating room you may have 15 pounds hanging, not 30 or 40 or whatever you might have in a closed reduction. Do you mind just going through that one more time? The major
yeah.
differences in how this is moving.
So I think if you notice in this illustration, the traction is applied and it distracts the disc space, and you can see that on this image. This is typically how it looks as you reduce it. You can see quite often there's a good bit of distraction, so you have to get the facets to unlock. Whereas in the OR, if you do it with traction, with serial traction, and that's how you reduce it fluoroscopically, it's the same mechanism. But usually if you're doing an open posterior, you'll put a towel clip on the
Mm,
cephalad spinous process, flex it forward to unlock the facets, and then drag it back over to pop it into place. And at the disc level, you're not getting any distraction. And so it tends to pull whatever interdiscal material or intervertebral material is back into the canal. So I think if you use traction weight and distract, it may be a little bit safer in line with an open or with a closed uh, reduction with traction.
I see.
So I think this is the problem with that, because this illustration is typically how we do. We get a towel clip, grab the spinous process, flex it, unlock the facets, and then just pull it back and pop it over.
So you'd say maybe even safer as another step to just cut the facets.
Um, Maybe, but you still drag the discs back. You still are dragging whatever that disc material is into the canal, as opposed to almost going up and over top of it.
I see.
I don't know. We obviously don't have any live MRI images to assure that's what's happening. But I think it's the translation without distraction that's the problem.
Yep, yep.
So I think if you have, and so in terms of timing of MRI, it is partially dependent. Oh boy, I don't know how to stop this. It is partially dependent on your access and patient stability. If the patient has a deficit, then I think it's very safe to do traction reduction and followed by MRI to assure the canal's open. So before you go to the OR, I think you need to get the MRI. In obtunded patients you can't examine, you probably should get the MRI first. The problem with that is that those are often the exact patient that are so unstable that they won't allow you to go to MRI. And so logistically, it can become a problem. So is MRI necessary before closed reduction of facet dislocation? I would say the data is overwhelmingly that no, it's not necessary before reduction. If you have an awake, reliable patient and there's no change in neurological status during the reduction, that you should obtain an MRI after reduction and before operative intervention, because that will dictate your approach. If you've already achieved a full reestablishment of the canal by your traction reduction and it's midnight, your stabilization can proceed in the morning and with a much better team, your preferred team, because you've essentially evacuated the canal, which is your priority. If you have disc herniation on the MRI, then you're going to have to go straight to the OR for the stabilization and the further decompression. But it's the decompression component that has the urgency. If you do opt to go straight to the OR for your reduction or anterior disc, which is an option, then you should get, I feel you should get an MRI prior. There are people who will say, I don't need an MRI because I'm going to take the disc out. Well, I do think it also better defines the anatomy of a disc herniation. And you may also have some posterior encroachment. I think you'll see on our example after reduction that the MRI is valuable before the MRI. Also, if you go to the OR and you attempt a traction reduction on the OR and it fails, that would certainly force you into an anterior procedure. You would not have an open reduction available to you. So in our patient, he had an awake traction reduction. It was completed with 49 pounds. So is the decompression complete? This was all completed within a few hours of the injury. So post-reduction MRI, it's hard to know what's behind the vertebral body. Getting back to the earlier question, is that just edema? But also, if you look here, I think because of the lamina fracture, there is still some posterior encroachment on the canal. So I think prior to proceeding to the MRI or the OR, this MRI is very helpful in our surgical planning, as you'll see later. So once we have a reduction and we verified the canal's open, we need to decide on our stabilization. This can be done anterior, posterior. Most of these can be handled by anterior, posterior alone, but there is a role for an anterior and posterior surgery. So classically, these were handled posteriorly. But if an anterior discectomy is required for persistent herniation, that's going to force you in an anterior surgery. And we'll talk about when we can do that as a standalone and when we should probably not do that as a standalone. Posterior stabilization is mechanically stronger. So if you're going to choose one over the other for mechanical purposes, it's the posterior approach. You'll see many of these handled anteriorly. And I think the reason is the ease of positioning. Anybody who does prone positioning for cervical surgery knows the challenges in that. And the positioning's substantially easier. The approach is easier. So we like doing anterior surgery. It tends to be less painful. And it does allow direct decompression of the disc surgery, which is, in my mind, a big advantage. However, you have to be aware of over distraction. The last remaining ligamentous attachment, often in these bilateral facets, is the anterior longitudinal ligament, and you're going to cut that. It's very easy to over distract it. In fact, sometimes it's hard to close down the vertebral body on your graft because it wants to over distract on its own. The other problem can be verification of the reduction. And I'm going to show some examples of this. In addition, some of these occur at the cervical thoracic junction and may be difficult to access. There are papers suggesting that it's less painful, the union rates are good, there's good post-operative alignment, lower infection rates. You can do a reduction of if you choose to go to the OR and say, I'm going to do an anterior discectomy and I'll just reduce it from the anterior approach. That can be done. And these are a couple techniques, one with a lamina spreader, one with Casper pins. So these are a couple different ways. You can use a lamina spreader, you can use Casper pins. Sometimes you can put a small cob into the disc space to weather a lever and get a reduction. And you can achieve reduction in most patients. The problem comes often in verification. And we'll talk about that. Anterior cervical, so if you do opt to go to the OR, do an anterior discectomy to relieve the pressure from the disc herniation, and then stabilize it anteriorly, you have to be aware of the contraindications to ACDF alone. And in particular, facet fractures and superior end plate fractures. If you do an ACDF, and that's your choice, and you have these contraindications existing, you probably need to flip them over and add a posterior instrumentation infusion at the same time. The risk for anterior failure, in order for an anterior cervical discectomy infusion to be effective, you have to get a buttressing effect from the facets. And if you see here, you have a buttress effect. If you over distract to the point that you can no longer get that buttress effect, they'll slide right past another one and dislocate. This is also true if you have a large facet fracture that prevents that abutment. And then lastly, end plate fractures, rigid spine. Here's some examples where ACDF failed. And this is an unrecognized vertebral body fracture. And these can be very subtle. You can see at first this looks very good, and in short order begins to fail, requiring revision not of the anterior but of the posterior. This is a similar patient. This particular patient had large facet fractures, a relative contraindication to ACDF, and in fact, they never even got this one reduced. And you can imagine what happens here is it fails in very short order. This is another example of the problem with going to an ACDF directly. In this patient, no MRI was done because their plan was to do an ACDF and then go directly to an anterior stabilization, and felt that it wouldn't add anything for the MRI because of the logistics. The problem is, and you can see their intraoperative imaging, it's hard to tell. If you see that image on the bottom right, you can imagine there's no way you're ever going to be able to verify that reduction fluoroscopically. And so this can be quite challenging, and sometimes they aren't reduced. If I can't see it and I can't visualize this, and this is how I've chose to do it, then I would bring the O-arm in to help verify it. And you can see this patient, the dislocation was never reduced and is doomed to failure. So adequate stabilization can be adequate alone, but posterior stabilization is biomechanically more predictable. The problem with the posterior approach is the positioning issue. It's biomechanically better because you restore the posterior tension band. It's very effective in reducing the fracture, and you can verify it directly by direct inspection. The trouble is the positioning, the pain, the higher infection rates. So in reality, I'd be pretty hard pressed to find one. And I've seen very few people present fractures that were stabilized posterior that have failed. I'm sure they exist, but those examples that I've shown you of failed anterior cervical surgery are very common, and those are all things that I've personally seen. So when you look at anterior versus posterior stabilization, it can be surgeon preference, but you do have to be cautious of facet fractures, vertebral end plate fractures, ankylosed spines, osteoporotic spines, and higher biomechanical areas such as cervical thoracic junction. Anterior posterior stabilization has some value. There are people that prefer to simply stabilize all of these anterior and posterior and get the advantages of both approaches. Sometimes the fracture pattern warrants this. The cervical thoracic junction, because of its stress, may be an area where you should consider it. If you require an anterior discectomy to reestablish the canal due to herniation, but either you're unable to reduce it or verify the reduction, then you're going to need to flip it posterior to complete the reduction. Also, if you've done it as an ACDF and you recognize there's significant facet fracture or there was some subtle vertebral body fracture, then you may want to flip them over and complete the stability with a posterior approach. Some people prefer it simply for the ease of rehab because they can feel they can remove the collar if they do a approach anterior and posterior. So in our patient, we weren't really sure what that was anteriorly, and getting back to the point, it could very well have been edema, but we did feel we needed to clear the disc to clear the canal. We also Felt that there was a little bit of a little bit of subtle end plate fracture uh, on the MRI stir images. So we flipped our patient over and established the greater stability with the posterior construct. And here's the patient at 2-year follow-up. Unfortunately, none of it helped him neurologically. He's still in Asia A, but the stability is preserved. Here's just some other examples of how it's very reasonable to do this. This is a patient, bilateral jump facets, a much milder deficit, had traction reduction that was successful. And you can see a post-reduction MRI shows no disc herniation. The canal's open, and this patient can be taken for a simple posterior instrumentation infusion. This is another example of one of our patients who was a 42-year-old, highly intoxicated, belligerent, jump facets with Asia C spinal cord injury. This patient we really couldn't examine. He couldn't cooperate for a traction reduction, required intubation. So we went to MRI first in this case, uh, and we didn't feel that was a disc herniation. We felt that was just edema behind the vertebral body. And in this patient, there's also some subtle end plate fracture on the stir image. So we took this patient to the OR. We did an open posterior reduction uh, because we felt it was safe, and reestablished the canal. When I use that kind of timing, in other words, when I can't achieve a traction reduction, I do an MRI scan and I feel that it's safe to do a posterior open reduction and stabilization. I always get a post-op MRI to make sure there's no disc herniation if the patient has deficit. If the patient was intact before that and is intact after surgery, there's probably no role for MRI. But if they have deficit, you want to absolutely verify that your procedure has in fact decompressed the cord. So I always use a post-op MRI in that situation. And this is the patient 3 months post-operatively. We had to do a pretty extensive instrumentation because of his previous fusion and stiffness of his spine, but he's neurologically improving. So if we want to summarize this, what are the goals of facet dislocation treatment? Well, the first goal is cord decompression. And we can do this with facet reduction, assuming no herniation. Anterior cervical discectomy is effective if there's a herniation causing cord compression. So to accomplish that goal, we can consider traction reduction or direct anterior disc. We want to achieve realignment. This also decompresses the canal. This can be done with traction reduction, anterior reduction, or open posterior reduction if we follow some of these principles. And then lastly, stabilization is kind of the secondary goal. If we've reduced the spine with traction, verified that the canal is open with a post-traction MRI, then the stabilization becomes a little less urgent. We can do it in the waking hours with our better team. And this can be done anterior, posterior, if you take into account the advantage of those. So what are acceptable
For
means?
your quick question, for your post traction MRI, are all your tongues MRI compatible? Do you take them
No,
off, or and if you
that's a
take them
good
off
question.
and they have facet fractures, yeah, what's your how do you work
That's a
through
good
that?
that's a good question. So we use stainless steel tongs to do our reduction because we have some carbon fiber tongs and we use those for a while, but they'll only take about 60 pounds of weight. And sometimes they're reduced within that, but often they require more weight. And if you try to put more weight on carbon fiber tongs, the C of the tong will start to spread and you can pull the tongs off the head. So we went back to using stainless steel tongs. After the reduction, we back the weight down to 15 pounds. We do another image, make sure that the reduction has been maintained. Then we put their collar on, remove the tongs, do another X-ray, verify they're still reduced. Then we go to MRI. It is a little bit of a nuisance, um, but the carbon fiber tongs will only hold 60 pounds of weight. So what are acceptable means and orders of achieving this? Because it can get very confusing, and I think we can follow a lot of paths if we understand this. So traction reduction, then MRI to assess for herniation, then the OR for either an anterior or posterior stabilization is all those are very acceptable. If they do have a disc herniation, then I think you're forced into an anterior approach in this situation. Assuming there's no contraindication to anterior alone stabilization, then you can be done with the procedure after an ACVF. If you are forced to go anterior by a disc herniation, but there are contraindications to anterior alone, then you should flip the patient either under that anesthesia or again in a more controlled situation, depending on timing, for a secondary posterior procedure as well. If the traction fails to achieve reduction, then an MRI should be done. If no disc herniation is present, then it's perfectly acceptable to do an open posterior reduction. If there's disc herniation present and the traction has failed, then I think you're forced into an anterior procedure and then hopefully anterior reduction. Another uh, uh, pathway would be directly to the OR for anterior disc and an open anterior reduction and stabilization. And again, you have to recognize any contraindications to anterior alone stability if you go down this path. And if those are present, you need to add a secondary posterior procedure. I still think if you choose this path, you're better off having a pre-op MRI because you can better define the anatomy. Okay. So if MRI is your first step and there's no disc herniation, and you say, I'm just going to go to the MRI, then to the OR, if there's no disc herniation, it's safe to do an open posterior reduction stabilization. If there's disc herniation present, then you should go anterior. The only absolute no-no is an open posterior reduction without MRI. Because this is the circumstance that's been described, and it's the only patient in the Eismont uh, case series that had a progressive deficit, was an open posterior reduction without preoperative MRI, thought to be due to disc herniation.
So, do you
So
think, can I ask you a quick question?
slides, but
Oh,
yes,
do you think our current, or I guess traditional thinking about who to do a closed reduction in the ED on is still correct? I guess what I'm asking is the intoxicated patient with a deficit and a facet dislocation. Um, should I guess my question is should they be getting a closed reduction attempt anyway, given the data that you've shown us here today,
yeah, I
and
think,
what seems to be really low risk of hurting them doing that versus the time you're going to lose, even if it's an hour or 2 hours,
yeah,
going to the, you know what I mean, going to the OR and not doing that.
I think it depends on degree of intoxication. If a patient's intoxicated, but they're being reasonable and you can examine them and they cooperate with your exam, I think it's fine to do a traction reduction. The example I showed you, that guy was not too long ago, and he was so drunk and belligerent, like we couldn't even get a good exam on him. He had a deficit; it was unclear. Different exams at different times. He was fighting with everything. Flailing his arms about. We thought that he wouldn't even cooperate for serial weight. So I think it depends on how intoxicated. Here's the challenging patient for me along those lines is, let's say, for example, we have the obtunded patient who has a head injury in addition to his jump facets. So we have no neuro exam. We don't know if that patient is intact or not. And quite often those patients are so unstable, they're not going to let us go to the MRI. So it's easy for us to say we should do an MRI before reduction, but that's the same patient that they're not going to let out of the ICU overnight. So we either have to decide, well, we don't think it's safe to do the reduction without MRI, so we're going to wait till they clear the patient to go to MRI, which may take a day or two, or knowing that it's typically very uncommon to get a deficit during the course of traction, we have a shared decision-making conversation with the family and decide that we're going to go ahead and do a serial traction reduction with the patient in the ICU, so that in most circumstances that has effectively decompressed the canal. And quite frankly, I've done that on a few occasions where I said, this isn't the board answer. This is a relatively uncommon situation, but if it was me, I wouldn't want to sit dislocated overnight, waiting for them to
Yeah.
clear to go to the MRI scan. And they're not going to clear them to go to the OR at that point. So we either go ahead and do a traction reduction, or we accept the fact that we're going to leave them dislocated overnight. And so I've gone ahead and done the reduction, knowing the data, particularly knowing the data on traction reduction, that it's pretty safe. That's not the board answer. I don't think we can answer that on the boards, but that's the reality answer.
Well, that's certainly what comes to mind. I mean, that's why I asked about the intoxic. I mean, that's exactly what I was getting at. When you present this, that's exactly what I think is kind of I would traditionally think might not be perfect in
Yeah.
some of these cases. Because I agree, I think if for me, I'd want you to get me reduced as well.
Yeah. So I think if we're going to do that, we have to pay really close attention to how much distraction we're getting. Because I think most of the time when they do develop a deficit during traction reduction, it's more likely from the distraction. So you got to really watch. If you feel like you're over distracting, you may want to back off if you don't have an exam. How much is over distraction? I don't have that answer. That would probably be your almost your gut feeling. And if you look, it might be like pornography. If you'll know it when you see it. But I would be careful of the distraction. Hopefully that clarifies things, because I think in our institutions, we all have different pathways, and the pathways can all work, but there are certain roadblocks to each of these pathways, and there are certain pitfalls to the pathways. So if you're aware of where the pitfalls are, you can follow a variety of these paths, and follow the principles of getting the reduction and the stabilization done correctly, based on your hospital's capability and your preferences. But you do have to pay attention to those pitfalls, or you'll fail. And I've seen a lot of failures of anterior alone surgery for this, so I'm very leery of it. I prefer posterior. If I go anterior for some reason, my threshold for backing it up posterior is very low. Uh,
Well, I think so. I mean, I'm certainly in a place where I think lucky that an MRI is often done very quickly when these injuries come in. Um, but it does make me think, and then we're going to the OR. It does make me think about whether we're underutilizing close reduction. So I'm fortunate because I oftentimes say, well, we oftentimes get the MRI right away and we're going to the OR, but in reality, we're probably still losing some time there, depending on everything else. But we're probably still losing some time. So it does make me think about whether we're underutilizing the close reduction some of these times and losing a couple hours.
I think
Uh,
if you have a mechanism for closed reduction within your hospital, I know for us, the quickest way, 100% to get the canal decompressed is a traction reduction. In some hospitals, it may not be the case. If you don't have a systematic mechanism to do a traction reduction, it can really be quite a flail. We do ours on the right on the Jackson table. So, on the Jackson bed, it allows us to put the patient in reverse Trendelenburg. We can change the flexion moment quite easily with the traction, and then we don't have to move the patient off the Jackson bed. We'll take him to MRI after our reduction. There's one patient movement onto the MRI table, back onto the Jackson bed, and we often go straight to the OR, sandwich the patient, flip prone if we're going to do a posterior uh, stabilization, and we flip them prone. We're all in the Jackson bed. We minimize our patient movement. Patient transfers from beds to tables are pretty dangerous in these patients. So that's our routine. And even in our place, these don't happen frequently enough, and it can be a bit of a fiasco. Um, using a traction reduction, even though we even have a written protocol on how it should be done and who should be there.
And is that typically you should be there or probably not, right? Probably the fellow should be there.
It's staff or fellow, and that usually means fellow.
Right, right.
But in all honesty, when we're doing these, the fellow and I are in. If it's in the middle of the night and I'm not there and the fellow's there, we're in constant communication. I look at the images and then we make decisions together on how to proceed.
Alex, do you have a similar approach to these? Do you guys have a mechanism for doing the close reductions, or are these going right to MR and right to surgery after that?
Yeah, thank you. I've relearned a lot. I remember Jens Chapman talking in Davos in a trauma course, and he said, "We are not chiropractors. We do a closed reduction protocol step by step, as exactly as you've described, John. But in Switzerland, the situation is a little bit different. So we are doing imaging. This is available 24/7. And usually we do MRI and then we go straight to the OR with the same concerns for posterior reduction as you've mentioned. It's a no-no without MRI to do a posterior. It's exactly the same. This are pretty well taught in the AO spine community. But we don't have a closed reduction protocol. So the ED is just armored with a telephone and they call us. And then we say emergency MRI and prepare the OR. So we have very early surgery. I think in Switzerland, you will be able to have a 6 hour window of um, decompression of the spinal cord and definite stabilization. You could do an RCT and you will achieve 6 hours in Switzerland. This is
Yeah.
my suggestion. But we also adopted the 24 hours now. But in Switzerland, we don't have the culture of closed reduction protocols.
Interesting when Staskus was when it first set up, the goal was 6 hours. And it turned out like even in the centers that were participating who were pushing as hard as they could to get them through, the number of patients that were actually decompressed within 6 hours was not high enough. So it was reset at 24 hours. I do think if you can get it done within 6 hours like you're able to, you're much better off. For us, that would usually be traction. I think it's perfectly reasonable if you have good MRI access and they come in and you say, all right, we're going to MRI. While we're in MRI, we're calling the OR. The OR will be setting up while we're in MRI because it's going to take them 45 minutes to an hour to be ready for you in most circumstances. You go to the MRI, and on the MRI, if there's what you're calling a disc herniation is present, then your strategy in the OR would be an ACDF to address the disc herniation and hopefully an anterior reduction of the facet dislocation. And then a
Yeah.
secondary posterior procedure if they have large facet fractures, if the facets look over distracted, if there's some superior end plate fracture. If you do the MRI and it does not appear there's any disc herniation, then you could go to the OR and do an open posterior reduction and stabilization pretty safely. If you have the latter circumstance, I would probably get a post-op MRI also to be absolutely certain I had the canal decompressed.
John, we've had some patients referred from anywhere in the world. I remember vividly a patient coming from any tropical island where he had this accident, and then it took like days to come to Switzerland. He was neuro intact, and then the question was just closed reduction because it was little pain, or a closed reduction and then fusion. Have you ever treated any patient you were able to reduce closed to treat with the collar conservatively, or do you all take them to surgery because of the severeness of the injury?
Yeah. I think that we've all seen patients that have had unilateral dislocations, which is a much more stable situation. And I operate on all those anyhow, but I've had patients come in that clearly had a unilateral facet dislocation. Many of them are now just auto fused in this partially sublux situation. They're doing fine. They may have some late pain or a little radicular symptoms, but that's a more stable thing. I think for bilateral facets, they're so unstable. I think you're gonna the likelihood of developing neurological deficit from progression is probably pretty high. So I don't think I would ever consider that. Certainly in bilateral facets, and in reality, there would have to be very special circumstances for me to consider it in the unilateral facet also.
And my last question would be, you've shown many cases of monosegmental posterior solutions. When do you go up to down, like in the thoracolumbar region? Because in our country, it's a little bit more common to do longer constructs and not monosegmental.
Yeah, I think if you have a large facet fracture or or you aren't confident that the lateral mass is going to hold a screw very well, then I think you need to add a level above and below. So then monosegmental fixation is not good enough. I think if you have stiffness to the spine, either due to their underlying disease, and it doesn't necessarily have to be ankylosed, it could just be a
Yeah,
very rigid, stiff, older spine. I'm going to go two above, two below at least. It could have been a surgical stiff spine, like I showed in our one example. The way I do it is when I have a reduction, I do an interspinous wire, and I put that in first, and I tighten that, and it locks in those facets. And so, if I have a small facet fracture, or the facets are intact, it just locks it in. It's very hard to get that to to sublux again. Then I put my lateral mass screws, almost like sort of a neutralization concept. Um, so I don't just do it with lateral mass screws. I don't trust them as well. If I couldn't put that wire in, say because there was a fracture at the spinous process at the base, then I might add additional levels of instrumentation. With that wire, in all honesty, you could probably put that in a lot of patients and be done. Years ago, that is what we did.
yeah,
Um, but we would often put them in a halo or some more aggressive external mobilization. But that wire adds a lot if you can do it.
yeah. And if you put something like a graft interspinous, you can add some compression with the wire as well. It's a beautiful way to enhance fusion rates. But it's a lost art, isn't it?
Yeah, yeah, but it adds a lot to your stability. I think that's what allows you to do them monosegmentally.
Yeah. And its costs is like $50, I
Yeah,
guess. It's
yeah,
so good, so effective. Yeah.
yeah. It's very simple to do.
Well, John, this was fantastic. I want to thank you again for doing this and going through all this. I always learn something from this, and really just outstanding. So thanks for letting us interrupt the skiing.
Yeah,
Sorry to get you off the slopes. I guess it's probably getting dark out there now, but thanks again for taking time out of the day to do this.
yeah. And sorry for the that auto advancement. I'm not still not quite sure how that happened. I don't think I've ever had a, but because I never used that, so that was interesting.
Oh, I
Added
think
add another challenging like we have during facet dislocation.
right. That's right. Yeah, way to work through it.
Yeah, probably made it more real. All right, hey, thank you for having me.
Yeah, thanks. Thank you again.
All right. All right.
Thank you very much. It was excellent.